Luc Sirois. Bonsoir, good evening. So it's a pleasure to have you all here tonight for this presentation lecture from Cathy Malas. It's actually the conclusion of the opening day of our 18th edition of our summer school on creativity for innovation management, partnership with Nantes and Barcelona, but also with many partners from our local ecosystems of innovation in aeronautics, in creative industries, in social innovation, and in healthcare. So it's a privilege to have Cathy with us tonight. I will let Patrick introduce Cathy Malas briefly.
It's difficult to introduce Cathy because at the same time she's such a friend, but she has a long experience about creating and conducting teams of innovation and artificial intelligence in many instances, in hospitals, first in Hospital Saint-Justine, then in the CHUM, the big hospital in Montreal, and now she's in the Jewish hospital at the Oroth incubator as a chief innovation officer. What she's doing is she really changing the world in hospital in terms of ecosystem of innovation by finding new devices with patients, with caregivers, with, of course, people of the hospital, with a lot of organization to change the work to, in fact, to practice health. So for many reasons, we are very proud to have Cathy. She's also adjunct professor in HEC Montréal in Laurent's department and member of Mosaic. And I must say, we also are very proud. She publishes in many high-ranked reviews and journals, but we are very proud with Laurent to have co-written a chapter of a book on ecosystem of innovation and communities, which is a beautiful article, by the way. She has something with Luc Sirois, who would be the discussant of what she explained. There are two, let's say, serial innovators. In life, they change the landscape of Quebec in terms of innovation. Luc Sirois is the chief innovator of Quebec. And same, he has changed many things. He has implemented Hacking Health, which is hackathon in health, now in something like 40 countries in 5 continents. So, as I said, I think we're very proud of welcoming them because they're real serial innovators. So, Cathy.
Merci. Bonsoir tout le monde. C'est un privilège d'être sur cette scène avec des amis et des anciens collègues et amis aussi. Merci d'être là ce soir. And what I'm sharing, I'll switch back to English. What I'm sharing today, it's the shared experience and knowledge of the 14 last years of innovation in Quebec and the health ecosystem. So what I'm sharing, it's a collective intelligence learning. So they asked me, Laurent, Patrick, and Lucie, as usual, very provocative title, which is the following. Is innovation essential and possible in health? Who answers yes? Hold on. Who answers yes, it's essential? Okay, now you can lower your hand. Now, is it possible? Yes or no? A bit less hands, but so let's showcase this together. So the health systems and healthcare organization are in crisis. And why are they in crisis? Number one, the needs of the patients, the caregivers, and the citizen are constantly changing. The picture that you have on the left is very a patient and hospital, very hospital-centric, disease-oriented, very highly medical equipment, centralized in academic university centers. At the time, we used to live less, so very acute disease-oriented. Today, we live longer because the innovation in medicine has allowed us to have new discoveries, treat better. We have technologies where we can care for patients and caregiver and their citizen at home. We have with AI the capacity to collect data and personalize more intervention And this change, the needs and the patient's needs and demands changing constantly, pushes us to constantly innovate. So that's the first why it's essential to innovate in the healthcare and in health organization. Number two, I don't know if you know, but by 2040, 1 out of 4 Canadian citizens will be 65 years old and over. That means by 2040, we'll also have seniors' healthcare spending increased by 88%, which is huge, and represents 71% of total health expenditure. That also pushes us to think differently. And you'll see we won't have more human resources, more beds in hospitals. So how can we care for our Ys, I like to say our Ys of our society, rather than our seniors or old age, to control also the next challenge is the following, rising of healthcare costs. The forecast in 2025, but this is the source of Canadian Institute for Health Information, $400 billion dedicated for health in Canada, which is 4.2% of the annual growth. The cost per Canadian head for health is $9,200, which is 13% of Canada's GDP. What's left for others? We cannot allow ourselves to continue to increase in expenditure and costs in the healthcare system. There is education that is as important, social justice. So we need to be responsible and have a viable way to offer health and care in a responsible way in our society. That's the other reason why we need to innovate. Number one, the needs are constantly changing. The reality of the health system is also changing. The aging population is continue to increase, and then we need to think differently how we can offer them care, and the healthcare cost is exploding throughout the years. The fourth reason is that the technologies, knowledge, speed, and AI is radically changing the paradigm. We've been talking about the 5 Ps in the healthcare system: personalized, predictive, preventive, participatory, and some say pertinent or public health, okay? So this knowledge of 5P, the 5 health in P, offering these 5 Ps in health could not be possible without technologies that capture data. Data not only on disease, but data on life habit, whether it be sleep, stress, nutrition, that enable us to take this type of data, cross them with genetic data, imagery data, and then offering a personalized treatment depending on the profile of the individual. This could not have been done without technology that capture data and artificial intelligence that enable us to use this data to personalize and do more preventative participatory health. The second thing that's radically changing, and when agentic AI, I'm not doing a presentation on AI, but agentic AI is really passing from recommending to action. Agents that be able to automatize process, doing an action to support a nurse or an administrative assistant. This is really changing the paradigm of how we see the workforce. What is the nurse of the future? What is the archivist of the future? What is the physician of the future? So this technology and the knowledge and AI is really shattering our industry, and we need to prepare for it. And this is why we need to innovate also. So that's the fourth reason. And last but not least, and this is something that's very dear to me, more than 1 in 2 nurses and physicians report experiencing burnout. I'm just going to pause. 1 in 2 nurses and physicians report experiencing burnout. These are the people that care for our citizen and our patient. And we know that each 10% reduction in physician task load, that's in the publication, was associated to 33% reduction in burnout risk. So there is human innovation that we need to absolutely push, supported by technology, to be able to support our workforce, our talent that work day to day to offer the best health and the best care for our population. And last, and that's the most dearest to my heart, is that unfortunately, there's still health inequities in the world. And let me give you some really statistics that break the heart. There is 18 years gap in average life expectancy between low and high income countries. 18. I'm not done. 30 years gap between countries with the lowest and high life expectancy. Childhood cancer survival exceeds 80% in high-income countries compared to 30% in low-income countries. A woman that's African-American has 8 more chances to die of labor than a white American. That is why innovation is essential. That is the most, for me, to my heart, reason why anyone that works directly or indirectly in the health industry needs to say, we need to innovate to better respond to the needs, to counter health inequities, and to support our workforce day-to-day in their daily work. So to the question, is innovation in health essential? I have to make you laugh a bit. Hell yeah. Hell yeah, for the future of our society. And now let's say, how is innovation in health possible? And for those that know me, I like to start with a story. What Patrick mentioned is that I had the privilege to lead the first team in innovation in Saint-Justine, then at the CHUM. I have some colleagues from the CHUM. Then I did a small hop in Montérégie-Ouest for 18 months, and then at the Jewish General Hospital. That story, it was my 3rd week at the Montérégie-Ouest. I was in the Hôpital Anna-Laberge, which is a périurbain, not that far from Montreal. And there's a geriatrician that approached me and said, Kathy, you know, I spend 2 hours per day in my clinical documentation at the end of the day. It's called pajama time for a physician. They finish their day, and then they need to write the clinical documentation. And then I told the Dr. X, and I'm like, I totally empathize. When I used to practice as a speech-language pathologist, I used to spend 3 hours per day. Clinical documentation is very important because for safety of the patient to circulate information. But 2 to 3 hours per day in clinical documentation cuts time of direct care for patient. And we as clinicians, we are trained for what? To care for patient. That's what we want, okay? So she's like, Kathy, I've seen this technology. That was in 2023. Still, scribes, today, AI scribes for clinicians are very popular. But at the time, we started to talk about it. She's like, I saw this technology that, that capture the interaction between, so I see my patient, I start this technology, the AI scribe, it records the interaction with the patient, and it pre-populates a clinical note, depending on, there's different standard of clinical, gabarit, templates of evaluation. It pre-populates it, and at the end, the clinician, whether it be physician, nursing, just validates the accuracy of the clinical documentation. Okay, this is called scribes, AI scribes. And then she's like, Kathy, do you think we can test it? Do you think we can try it? And then she's like, we can try it with nurses, speech-language pathologists, occupational therapists. What do you think my answer was? Hell yeah. Not yes, hell yeah. Why? She's like, you know, I think it can save time in clinical documentation. I think we can use this time to care for more patients. I think it will reduce my cognitive burden at the end of the week when I finish my week with delays in clinical documentation. And I think it will improve staff experience. She already had her value hypothesis. She already had benefits in her mind. And then I'm like, hell yeah, we're gonna try it and we're gonna test it together. This story will follow me for the rest of the presentation. In any innovation strategy in an organization, whatever organization you are in, it has to start with the why, okay? In all my organization, the mission of innovation was always almost the same. Through user-centric innovation, through innovation, we reimagine the future of global health and we improve people's lives. It really touched me when you said that we want to change the world. Exactly. We innovate in order to improve people's life and change the world while creating sustainable values for patient first, for our teams, our partners, and our communities. This leitmotif, always, we don't innovate to innovate, we innovate to improve lives, is something that followed me whatever the organization I was in, and it's the start of a strong culture of innovation. The second, in the why, there's creating value. Whether it be the value, there's 2 frameworks, dominant frameworks to capture value or impact of innovation. There's a value-based healthcare, and there's the quintuple aim in health. But ultimately, it's all the same. We innovate, we integrate technologies or AI to improve patients' experience and clinical outcomes reported by them or by the caregivers, to improve population health, quality of life, social reinsertion, to reduce costs. We need to be responsible. We can't expect healthcare expenditure to continue to explode. So we need to innovate to reduce cost, to improve the well-being of the teams. So the story of Dr. X was around that, right? Improving direct care for patient and improving the staff's experience, and finally innovating for health equity. So in the why of innovation, it's very important that when we move a strong culture of innovation in an organization such as the healthcare system, the why needs to be very clear. Now, after the why, I like the 3 pillars. We've tested it in more than one organization, and it works, okay? So there's different ingredients in 3 main pillars, and I want to start with the most important pillar, which is the people and the teams. In this pillar, the ultimate objective is to inspire people, and I'm sure Luc and I will talk about that. So what are the ingredients in this pillar of teams and people? Number 1, empowerment. One of the questions that often people ask me is that, Kathy, what is the key ingredient as a director or chief innovation officer? I'm like, c'est l'art de se rendre inutile. How do you say that in English? It's the art of being useless. In the sense, when you are useless in a team, that means people are empowered. They have the tools, the skill set, the competency, the support in order to innovate. And empowerment is at all levels of organization. But innovation is, there is processes, I'll come back to it, but the top-down approach where the people, Dr. X, when she approached me, she didn't ask for permission. She asked for help. But she was empowered to say, I have a problem, I'll solve it. And I'll give you other stories later on to describe the importance of the ecosystem. People, a strong culture of innovation or creativity in an organization, people need to feel that they're agent of change, agent of innovation, and they're empowered to find solution to their own problem. So empowerment for me is a key ingredient in this pillar. Second one, they're missing an R. There are prerequisites to be able to innovate. Le droit à l'erreur, the legitimizing error, taking risk, learning, the capacity to learn, le droit d'apprendre. My favorite one is respectful delinquency, and I'll explain. In an organization such as the healthcare system, there's lots of protocols and procedures, right? And we need to respect protocols and procedures. They are very relevant as long as they respond to the patient's need. And I'll give you an example. I was a speech-language pathologist, and I used to use a protocol to diagnose multilingual autistic children. I was young, I just exited university, and I tried 1 time, 2 times. I'm like, man, it doesn't give the right results. So the protocol for that subpopulation didn't work. So I dared to say, let's change it. And then I had, no, it's protocol, evidence-based practice. I'm like, well, it's not working with this subpopulation. So I did respectful delinquency. I contacted the professor at the Université de Montréal. I'm like, would you want to train this protocol? At the time, we didn't have AI, but we had protocols from science that we validated. And then we adapted this tool for autistic children. So very important, respectful delinquency. When a procedure or process does not respect and respond to the needs of the clients that we serve, we need to challenge the status quo, try, demonstrate it works, and then ask for forgiveness after. That's my favorite prerequisite. And then incentives. Incentive, the most important one is protected time. Even physicians, physicians do not ask to be paid to innovate. What they want is time to innovate, time to reflect, time to experiment, time to measure, time to fail and learn. That's what they ask. They ask for protected time to be able to challenge the status quo to better respond to the patient's needs. There's other incentives, recognition, valorizing, recognizing successes, but also celebrating errors and learnings. And finally, the last ingredient, there's multiple others, but this one is very important. And we've done this together in the last year. We've built competency programs, and with Denis too, on how to innovate. So there's competencies and knowledge how to innovate. So across all the organization and the teams I had the privilege to work with, we did different series of innovation. In the morning, at lunch, we built training programs with the Center of Expertise for the Management of Innovation with HEC, le Conseil d'innovation du Québec, at the time when I was at the CHUM and the Ministry of Health and its Innovation Office at Orot, which is our innovation incubator at the Jewish General Hospital. We have a community of practice that is very open. There's also a community of practice provincially that's still living. Knowledge sharing and competency development in innovation and creativity is very important to be able to empower the people on the ground for them to solve their own problem. So, first pillar, the teams and the people. 3 ingredients, there's more, but empowerment, prerequisites, incentives, and knowledge sharing and competency development of the people on the ground that innovates day to day. The second pillar, it's the organization that facilitates innovation within its wall. Let me start by the first one, the notion of ambidextrous health organization. Did you speak about ambidextrous? Not yet, most probably not. Okay, so any organization, such as the healthcare system, we need to operate. We need to manage operation, okay? Which is offering care to our patients. For example, the imagery department is doing imagery for the patient, for the labs, for the kitchen, for hygiene and salubrité, hygiene and salubrité? Salubrity, yeah, it's to clean the rooms. So we need to offer operation, production. But we also need a function to innovate, which is exploring, innovating. So there's multiple articles that talks about, one of our dear colleague at HEC, Dr. Anne Langley, talks about the interplay between reflective and experimental spaces and routines to improve routine dynamics. Routines is the operation. A protocol is a routine. A process of care is a routine. To improve the routines, we need reflective and experimental space. I wrote a paper in CIUSSS. I like to dance, so I called it the valse between operation and innovation. You need innovation space to think this practice is not working. How can I refract? How can I design? How can I test? How can I learn? How can I improve my operations? And during COVID with Carl-Emmanuel Dion, also a colleague from HEC, we wrote a paper on the importance of local knowledge that we used to recreate protocols during COVID. We experimented them quickly, and then it modified the routine. So this is the notion of ambidextrous organization that have a dual function of managing operation, but also a function of innovation to serve and improve operation with our routine and practices and processes. So that's the first ingredient. Any organization, and you'll visit multiple organizations, need to manage innovation and operations to improve their operations. Second key ingredient, a dedicated innovation team. So all my innovation teams that I had the privilege to work with, whether it starts with n equals 1, and then it grows to n equals 2, and then 3, 4, but it's never huge teams, but you need a dedicated team that will hold the following items that I will describe. This innovation team hold the process of innovation. So as Laurent often says, yes, innovation starts with creativity, but at a certain point you need to manage it, okay? There's processes. So here's a process, whether it be any organization, they use the same step, but it all starts, and I go back to Dr. X, the geriatric, it started with a problem or a need. Then she validated if it was relevant to other staff, not only to geriatrician. Then, in that case, we didn't co-develop, but we approached an industry partner, and we said, let's test the solution. Let's see if it confirms the value. Gain in time, reinvesting this time to direct care, reducing cognitive burden, increase staff experience. So we tested, we experimented, we evaluated. Once the preliminary value hypothesis are confirmed, then we evaluate on a larger scale. At the beginning, we started with 20 staff, around 50 patients. Then we scaled, for example, at the Jewish General Hospital, we scaled to 150 staff, measuring the same value outcome. So if you evaluate at larger scale, if it's confirmed, if there is value, then we diffuse. If it's an industry company, they commercialize. And finally, if there's value that's still confirmed, we need to sustain innovation, which is still a big challenge in our ecosystem. So that innovation, that process is held and facilitated by orchestrators such as an innovation team. However, it's not sufficient. We also need methods. So this is where we had fun in the last 14 years together, right? So we did hackathons and promptathons and innovation workshop and design, where, again, it's always the same philosophy. with the people on the ground, we take problems, we co-create a prototype, we go back on the ground, we test it. Some solutions are co-created with patients when it touches the patients directly and their caregivers. But we need methods, and this week you'll see different methods and tools to be creative and to, again, in our industry, we're creative to actually improve the lives of the people, and that translates in innovation. So an ambidextrous organization that legitimizes managing operation and innovation, a dedicated team to support innovation that walk the people on the ground, like Dr. X, across the innovation cycle as a process, and that proposes methods of creativity and innovation to translate these ideas and problems into concrete solutions that create value or that fail and we learned. As important. I always say the journey is as important as the result. And finally, the last one is value measurement. So let me conclude to you the story of Dr. X, and we were 5 nurses and maybe 3 occupational therapists and physiotherapists. So I'll give you some results in the literature and give you some results, not where at the organization where I was, but at the Jewish General Hospital and our Santé Québec Centre-Ouest. So look at the results. In the New England Journal of Medicine, it says that, did a study with 15,700 physicians, 2 million patient encounter, and that demonstrated that 20 to 30% reduction time for clinical documentation. We measured at Centre-Ouest, now we are called Santé Québec Centre-Ouest. We used to be called the CIUSSS Centre-Ouest. For those that know Quebec, it's a recent change. Je vais m'enfarger avec les mots là, pour le reste de la présentation. So we measured 0.07, which is 5 minutes, to 40 minutes of clinical documentation saved. There was a mix of social worker, physician, and nurses, which is significant. Okay? Again, go back to 1 or 2 workers suffer from burnout, and by reducing 10%, you've decreased burnout by 33%. This contributes to reduction in burnout of our staff. Second, better clinician experience and patient interaction. So in the published evidence, whether it be in the New England or the JAMA paper, 30% less pajama time. That means the physician finished their day and spent less time after hours. Better concentration of the physician and higher satisfaction from them. On our end, we measured more direct patient interaction, positive note quality, because it's important. Clinicians need to trust the AI. They need to make sure that there was a mistake, like 0% hallucination was an only subgroup, but the rest we were between 5 to 10% hallucination, that means error by the AI scribe. So it was important that the clinician mentioned that it had a positive, like the clinical documentation was not that bad. Okay? So that's for the second value creation. And the last one, the system level and financial value. So in the published evidence, the 15,700 documentation hours eliminated, the 15,700 was the hours eliminated by the 7,000 physicians, okay? Which is significant, that means more patient time. And what we measured, 51% of overtime reduction for social worker at the ED, and the social workers have a deontological code that they have to write the clinical documentation in 72 hours. That was also respected. And finally, the return on investment, the cost on the benefit, $1 for $1 invested, $1.73 saved, which is significant. But the most important, if I go back to the story of Dr. X, we saved time for clinical documentation. It increased her direct time for patient. It increased staff experience. And we didn't measure it here, but the hypothesis is reduction of cognitive burden that was not measured in the papers that you see here. The last ingredient, the last pillar, is that people and teams that are empowered, inspired, with an organization that facilitates through spaces to reflect, to innovate, to experiment, with a dedicated team, with processes, with methods, and with value measurement is great. But that sometimes, and COVID demonstrated, any crisis demonstrated us, you don't always have the expertise and the knowledge within your organization. So you need to go beyond your organization to mobilize talent, resources to be able to solve a problem. An ecosystem is organized, and that you will see throughout the week, right? Yes. So an ecosystem is an organization from different field of a same industry or different industry that take a problem, any problem, they have a common objective to solve the problem, and they share resources, human funding, to solve that problem. That's an ecosystem. So one of my coup de cœur of innovation in my career is Espace Transition. Every single time I talk about it, because it moves me every single time I talk about it. So it was at 2000, what are we today? 2026, 15 years ago. Patricia Garel, which is a pedopsychiatrist, child psychiatrist, with educator, Kim, approached me and Dr. Brunet, at the time the CEO at Saint-Justine, and said, Dr. Brunet, we created 2 things. What did you create? They're like, our mental health children that are hospitalized in psychiatric wards have difficulty to reinsert socially back in their real life. So we wanted to increase social reinsertion of our youth back into their day-to-day life. Like, amazing, that's a true problem. How did you solve it? Listen to that. She's like, we approached 2 industries in Quebec. I'll never forget. Dr. Roseman said, which ones? Musée des Beaux-Arts et le Cirque du Soleil. I'm like, oh, interesting. 2 small Quebec industries. And we created, with the youth, we co-created l'art du scène, l'art de la scène, arts of the sea, no, I mean, Cirque du Soleil, they do different prestations artistiques, and in the Musée des Beaux-Arts, a day in the musée, okay? So youth with and without mental health. The youth didn't know who had mental health problem or not. With artists and intervenant clinicians, they co-built a series of 6 to 12 sessions where throughout art, they worked on communication, anxiety control, social expression, different clinical objective. The clinicians were not, the artists did not apply art therapy. They used the art to work on expression, communication, interaction, and our clinician worked indirectly on these clinical objectives. So they co-created this with the Cirque du Soleil et le Musée des Beaux-Arts, and then they're like, but we are limited, we need support now from the organization. Funding was one of them, but it was not exclusively funding. They wanted us to open doors to other organizations. What did you think Dr. Brunet answered? Hell yeah, of course. And then, so since then, today, Espace Transition has multiple artistic and cultural organizations, small and bigger. They co-created à la découverte du violoncelle, the dance, opera, cooking activities, etc., with different local artistic organizations. And today, this program is scaled across Quebec in 15 organizations. 15 years later, this social innovation is still sustained. It's impressive. It is impressive. And that's a demonstration of, again, the 3 pillars. Patricia Garel, empowered to solve a problem. She came and asked for support of the organization, an organization that facilitates innovation. An innovation team that came, supported her punctually. But she, from day one, she opened to her ecosystem, the artistic, the art et culture ecosystem, locally, and this is what I gave for this youth, and they were, let me give you some results. The studies, because we did a research, multiple research project, it significantly improved the well-being of the youth and their social functioning. There was a reduction in depressive humor post-program, and there was significant management of their self-esteem 5 months later after the program. So this value was sustained also from these youth after they left the program. A last example, and I'll finish with that, is also another example of innovation that went beyond an organization, and that translates to organizations. So when I was at the CHUM in 2021 during COVID, we anticipated a backlog of appointments for oncology patient. Everything that was prioritized was COVID patient. We operated less. and then we anticipated a backlog of waiting time for oncology patients. So with the spin-off of Polytechnique, and it was financed by different bailleurs de fonds, financial envelopes from the federal and provincial, we co-created a tool to optimize scheduling for oncology patient in chemotherapy and radiotherapy. When you book an appointment in the healthcare system, it's not like booking an appointment in your garagist. It's 25 variables to consider. Availability of the patient, availability of the technician, types of radiotherapy, length of the duration. So 25 to 30 variables to consider to optimize the schedule from Monday morning at 7 o'clock till Sunday evening at 8 p.m. Okay? Human beings are very smart, but this is where the machine can have an added value. So we took the problem, we co-wrote the grant, we co-built the prototype, we co-measured the value proposition, which is increasing the time, increases access to care, which is chemotherapy or radiotherapy intervention, reducing the time to book appointments for the staff, and staff experience. So here's the results that was measured at the CHUM, and that was translated at the Jewish General Hospital. 10% in access to treatment, because we fully optimized the schedule. 50 to 80% time saved to book the appointments, and plus 90% staff satisfaction of this tool. Again, developed, implemented in one organization, scaled and adopted to another organization. Again, that was not possible without the mobilization of individuals that understood the problem, open to the ecosystem where we went and worked with engineering schools, companies, and now today this solution is sustained in more than 6 organizations. So to the question, I want to conclude with that. In health, is innovation essential and possible to improve people's life? I hope I demonstrated it through the presentation. And again, I'll leave you with this wonderful child. Is innovation possible in the healthcare system? Hell yeah, thank you. Thank you so much. So now we're here. What Luc Sirois, our innovator-in-chief of Quebec, thinks of all of
moi, I'm president of our followers club and fan club with you. Who here knew Cathy Malas? Who here knew Cathy? Oh, you already have members of the fan club. Who here did not know Cathy Malas? All right. And who here finds Cathy Malas very inspiring? All right. Cathy, wow, wow, wow. It's great. You started, the first word you said is shared. We're gonna, this is shared learnings. You said it's about learning together. You've learned for a couple of decades how you started. You were a clinician, and all this science of how you achieve healthcare innovation in healthcare. You kind of learned and grew over the years, and now we all listen to that, and it seems so kind of obvious and so easy.
Not easy. Obvious, maybe not easy.
But that's my question. It seems so obvious. It seems like a clear path with clear approaches on how to do it. Why isn't it done more than that?
Yeah, so I'll answer and then I'll pass the puck back to him because he has good thoughts on that. I mean, it became obvious because we weren't alone, right? We started this journey together. Remember when we did the hackathon in 2014? We didn't know what a what? Who knows what a hackathon is? Okay, it's take problems in an open innovation. You bring developers, programmers, designers, citizens, and you created a prototype in 2 weeks and in 2 days and a half. When Luc Sirois came at the time when we were at Saint-Justine, and he said, "Let's do that." Hack à quoi? Did you know the impact of hackathon when you started?
I didn't realize like it'd be like unleashing the power of people. It just blew my mind.
Yeah. And did we know the science that much? There is science around innovation, but innovation in health, we developed this together. And I think this is, I believe, one of the most important points is that we learned together, we documented together, we published together, we failed and we learned together. So I think one of the reason why we're here today, and I think Quebec is in a better posture than in health. I'm only talking about the health industry, in a better posture than in 2012, 2014. It's because we tried to implement the science of innovation in an industry such as health, and we measured.
But can I be skeptical
Yes,
just
please.
a little bit?
Be
Can I?
skeptical.
Like it seems like if it was done and industrialized and systematized everywhere and in repetition, we'd be elsewhere, wouldn't we?
Yes, indeed. And I think not all organizations see innovation as a strategic asset and make it a priority. Having the right people to support that also can be a challenge. And I want to throw back the question at you, because with the...
you're not going to get
Yes,
off
yes.
the hook that easily.
I'll come. So, Luc, we, at the Conseil de l'Innovation du Québec, we did a big survey. We measured the capacity to innovate within Quebec. And do you want to share one of the results? And I'll come back to it. That's very percutant. That's
Yeah, well, a couple of things. First, it's about only half of enterprises in Quebec that say that they innovate, which is, working on a new product or a new process or improving a way of doing things. And of those who don't do it, which is 45%, like a big half.
think what?
That it's not necessary.
Can you imagine? And what did our pivot study demonstrate?
It's not necessary. Why? I mean, then if they do implement leadership support, having the head of the organization say, we want it, you're allowed to do it, and we're going to support it. Just saying we want it makes a difference. Number two, you highlighted it, having processes. The number two was kind of organization, having people in charge.
Exactly.
Like our friend Yves Pignard would tell us, but it's demonstrated. When you got someone in charge, you alluded to having a team, makes a difference because people care about it full time.
Exactly.
And the third was processes. There's need to be ways of doing it, which is not by inventing your way through it all the time.
Well, here you give the answer to your question. Now,
So do we kind of, I mean, we have people that are taking notes and they're all going to go home and be agents of change. So we must give them something to do. And is it to seed kind of the leadership? Is it a matter of making sure we have Dr. Brunez and Cathy Malas, an organization that kind of blow the horn?
I mean, what I presented today as a learning of the 12 last years is it's not one ingredient, right? And this is what Yves Pignard also developed as a tool is, for sure, the CEO, and I had the privilege to work with Dr. Brunet, Philippe Riboval, Dr. Rosenberg, that make it a priority, but it's not sufficient. You know that. There's industries where the top says yes, but then it doesn't follow. Innovation team supports processes. So my key message and learning is that c'est multifactorial. Every ingredient is important. One is not enough. But it needs absolutely, because I lived a change of CEOs, when a CEO does not prioritize innovation as a core capability and strategic objectives, then innovation has a harder time, and the empowerment of the team on the ground have a harder time to kick in. Yeah.
How do you go about convincing them? What's your trick to make them to engage them? And
I knew it's going to be hard with Luc Sirois, which is one of my models for innovation. So what is the trick to convince what? The teams or the CEO?
The CEOs, like to get on board with that vision.
So number one trick didn't work all the time, but one trick that I used is that you need to demonstrate how innovation will improve operation and the pain points of the CEO. Okay? So one time it's budget constraints. Okay? How can innovation help you select where to cut, which is hard. And this is where frugal innovation is important. Innovation is not always with more resources. It's sometimes using what you have to just do differently and then save time, save costs. So,
and sometimes innovating is stopping something.
Is something, exactly, stopping something. So number one, identifying the real pain points of the CEO, what's stopping him from sleeping at night, and convincing him that the innovation will create some value. That's one thing. Second thing is demonstrating that it will help him mobilize his organization.
Uh-huh. Well, and it leads to, you ask, like, is it to convince the CEO or the people in the organization? Like, are they hard to convince?
The ground,
Yeah.
I think the easiest people to convince is the people on the ground, because it's common sense. And I always say the same story. When Mary is the person that cleans the floor after hours. And I asked her, Mary, what does innovation mean for you? She's like, I don't innovate. No. I mean, you didn't answer my question. What does innovation mean for you? She's like, doing something differently. She's like, oh, for example, my chariot.
Your buggy or
Yes.
yeah,
With the mop and the lingette. And she's like, they always come back at the end of the quarter, le quart de travail, always upside down. So she's like, I had an idea. I'm like, what is it? She's like, I created visual repère.
like instructions and,
Yes,
and visual.
the mop goes here, and then she put the visual cue, and the lingette goes here. And then she optimized the route by 10 minutes per quart de travail per person.
Oh.
So I'm like, Mary, that's innovation. She's like, oh, well, I innovate then. What did it take? A conversation of 7 minutes.
Wow.
So I always say the greatest, there's two reasons why when we're in health and we're all working directly in health is, number one, what's your leitmotif is the patient. The patient and
Yeah.
the caregivers and
That's
the
a
caregiver.
great common
Yeah, I mean-
cause and a kind of a something
But
that,
c'est un
that
call,
provides
a
sense.
mission.
Yes,
Exactly. When I'm down, I walk the hospital. I go see the patients. I see their caregivers. It reminds us the bigger why.
Yeah.
But the second,
And the greater purpose.
exactly, and the second leitmotif is the workers on the ground.
Uh-huh. And that's fantastic that you highlighted this as one of the key reasons, the kind of caregivers' well-being. And I have the privilege to live with caregiver, and it's tough. I mean, and you have some here in the room, and it's tough, emotionally tough. It's demanding. It's exhausting. You've seen those stats of burnout, and you put this as one of the priority. It must heal their heart.
So two things. There's a burnout of staff and there's the burnout of caregivers. So I have the privilege to lead the hospital at home program, which is very novel. And today there's multiple organizations that once you're relatively stable, you have a caregiver that can accompany you at home. You're still admitted, but we care for you at home. So you're hospitalized at home. This is great. Like, who doesn't want to sleep at the end of the day? And their bed, we monitor them 24/7 with nurses and physicians with connected objects, with IoTs that monitor them. But one of the key indicators that we are not great at is the burden of caregiver. So the acceptable burden is 20%. That's general number. We are at 40% burden of caregiver. But despite that, 93% recommend hospital at home, and the caregivers 86%.
Huh.
So our job
So it's more burden, it's more work.
for the caregiver,
For the
for the husband or the wife, the child, because you have to care for your
That's right.
loved one at home. You need to cook. You need to lift them to go to the bathroom. So, despite the fact that we have higher value for the patient, discomfort is less, patient experience is better, we have higher burden on caregiver. So our priority of innovation this year for the hospital at home program is to innovate for reducing caregiver burden. So that's one example of burden. The other burden I was describing in the stats, which is the burnout of nurses and physicians and allied
the clinical providers.
1 on 2, it's significant. So, and it's not like AI is promising and technology is promising, but it's still for them sometimes perceived another layer of tool. And this is where we need to make sure that we deploy this AI and technology in a seamless way in their operation, so it doesn't add the burden. And this is where user-centric design is very important.
Maybe one last question, if I may, my dear friends. I mean, for the people in the room, you know, all kind of aspire to eventually be a change maker and a leader of innovation like you in their own organizations, whether it's healthcare or not, what advice would you give them on how to start or to accelerate, and what should they do?
And then I'm going to ask you the same question, okay? Repeat the question. What advice?
What advice would you give the people in the room on how to start their journey of...
Keep your why close to your heart. Don't stay alone. Find a colleague. If you have an innovation team to support you, go knock on their door. If you don't, knock at the university door, knock at Luc-Sirois' door, knock on the door. Don't stay alone. But keep the why to your heart. Don't stay alone. Go ask for support from the higher up of the organization. Be respectful, delinquent. Try stuff. Ask for forgiveness after.
This is so cool. Respectful, delinquent.
And you? What is your advice?
Well, you're my teacher in that. We started the talk with this word shared learnings, and this is what you bring back as the closure again. Don't do this alone. Don't do this alone. And one teaching you brought us as we were putting together situations and programs is to kind of the why. You mentioned it again. Keep the eyes on the common goal.
Yeah.
Kind of raise your own views and have a shared view of what together you're trying to achieve. For me, that was words of wisdom from you, Cathy.
C'est réciproque, Luc. Thank you.
Cathy Malas,
Thank you. Thank you.
Bravo.
Maybe again, thanks a lot, Cathy and Luc. Listening to them, I must confess that I felt the magic of Montreal. The magic of Montreal for many reasons in terms of innovation and creativity. First, you have exceptional people, orchestrator of innovation. Cathy and Luc, we have in Montreal exceptional people. Second, as Cathy said, for example, of Espace pour la Vie, you are an ecosystem where you can find solutions with Cirque du Soleil, with Fine Art Museum, with Conseil de l'Innovation, and for instance, in Mosaic, you would go to the Cirque du Soleil, and on Monday you would listen to an exceptional presentation by Nathalie Bondil. She was a former director of the Musée des Beaux-Arts, and she was the one that orchestrated the Espace Transition. So I think this is kind of the magic of Montreal, where you have at the same time an ecosystem where different companies like Cirque du Soleil, Ubisoft, Musée des Beaux-Arts, Hydro-Québec work together to find solutions in exceptional domains, which are for the benefit of society and humanity. So I think I'm sure in Nantes and in Barcelona it's the same, but not in all cities in the world. You have something special here.
And it's something that Cathy said, this ecosystem, the third pillar that you brought out to say, hey, to go further, go out and pull in those resources or have an impact. And I think it calls upon the inner flames in people's desire to have an impact. When you ask the question about what did you think hackathons would have such an impact? It unleashes the aspiration of people to make a difference.
C'est exactement ça. Montreal still remains one of the biggest hackathon ever, right? 600 people.
Yeah, 800.
We didn't know what a hackathon was. Well, I didn't know. He knew a bit. And then we studied it and we published on it. But 600 people in the amphitheater on Sunday, February 22nd, 2014. I'll never forget that day.
Yeah, it was something. And I'm sure you know what this is. I mean, you're all here with a desire to make a difference, have an impact. If you call upon, like this is an example of a hackathon, Patrick is giving the example of calling upon an ecosystem or enterprises in the world. I'm sure that in Barcelona, in Nantes, and elsewhere, you go and call upon people and their desire to make an impact, you'll get help.
Cathy, if I may, we mentioned the ecosystem, the communities. You mentioned the physicians, the nurses, the employees. What about the role of the patients in the innovation process?
Yeah, so the two examples I gave, the AI tools were more staff-oriented, but Espace Transition is 100% patient-led. I can give another example. Another AI tool that I believe is phenomenal, that changed my life and my family's, Emilia. Emilia is a scribe for patients. So download it on your app store. It's called Emilia. My dad has a literacy in health low. So when he goes to his appointments, he doesn't understand much. He understands French and English, but health literacy, the capacity to understand health language is low. So he exited the appointment and he says to the physician, yes, I understood everything. When he exits, he's like, I didn't understand anything. I'm like, why didn't you tell him? He's like, no, je vais pas perdre ma face. Right? He has ego, my father. He's not going to say, I didn't understand anything. So Emilia, this tool, was co-created with patients. So they built this technology of AI Scribe for patients, where the patient can ask. So my dad, just to make you laugh, and then we'll go to your question. He's like, how will I introduce the tool to my physician or to the audiologist? I'm like, say that I will chicane you if you don't summarize the appointment. So comment on dit chicaner en anglais?
Scold and scold.
Scold. I'm like, tell your physician that I will scold you if you don't come back with a summary. So he did that. The first appointment, he's like, my daughter will chicane me if I don't remember everything. Can I record the session? They all say yes. No one said no. And it does a perfect summary of the interaction, very simply. 5 bullet points, the diagnostic, the treatment plan. And now he's more confident to go alone to an appointment, and I'm less stressed when he goes alone to an appointment. That was created with patient. Quebecer solution, built with patients, for the patients, and it is so essential. That's the only way to adopt innovation to practice, is to co-create it with the users, which include patients.
Do we have
Yes, please,
questions in the room?
For any one of us.
Reactions and astonishments and comments and words of wisdom, or
Denis.
Oui, Denis.
Yes.
It's not a good start. I think the game is over. So you have to be sure the CEO, it's a DNA of the CEO, the nature of innovation, the part of it. You don't have to condense it.
That's true.
It's too late if you are there. So that's, I think,
That's why I think you need to figure out ways to convince them. Otherwise, I mean, if you want the revolution to happen faster, they need to get on board. I thought it was a good way to go. Just show them the dollar savings and the efficiency increase and the overtime reductions and the burnout and the ways. No, you say no. Yeah.
No, but what's alarming, and you're right, Luc, is that in our industry survey, half of the 50% said they didn't find a need.
Half of the enterprise and the CEOs that do not innovate say because they don't need it.
And then 30%, exactly. And what's your experience? How did you convince that in Quebec we need to innovate? Because he's too humble. Luc significantly changed the ecosystem of innovation in Quebec, not only in health, but beyond. And I do by purpose by throwing him back the question, because we have lots to learn also from you. So how did you're the innovator of Chief in Quebec. How did we convince the...
Well, one trick I use, you asked me about these survey questions and this statistics. I shamed them with data. I show them their rankings.
Here you go.
When they're at the top, they want to stay there. When they're at the bottom of the class, they say that can't be. I said, well, I'm not arguing. I'm just showing you data. There's kind of an emulation.
Oui, 100%.
So somehow this or inspiring them. I also do it in a positive way. You know, I show how their peers or competitors do and how great they are.
Yeah. And then one last comment, and then we'll take another question. It is so magical when you have CEOs that truly enact innovation. Like, I'm currently in an organization where Dr. Rosenberg, still standing firm in a healthcare system that is en turbulence, and still says innovation is as important as operations. We need to dedicate time to reflect, to experiment, to invest. Money is not the issue. When you have a dream, when you have ambition, when you prioritize, things happen. And so the other 50, it's truly inspiring. So I was a clinician on the ground. Dr. Brunet like, do you want to participate to a hackathon? I'm like, yeah, no choice. But it's truly the culture that it brings with an organization is truly magical. Truly magical.
I think we have a question on my right.
Lots of questions. I like questions.
We do have questions now. Good.
Hello, thank you. Thank you very much for the presentation. I have a question for Cathy. How do you promote your department and your services among the other departments?
Oh, it's
I
such
know
a good
sometimes
question.
There are strategies and programs and showcasing. And what do you have in your institution?
So
It's a good question, eh?
the first one is that today we don't need marketing and promotion because we demonstrated value. But when you start with a team, an innovation team, when people don't know you exist, when you're at the start of your journey, I always say, don't market. Find one or two problems, solve it, demonstrate that is value, then showcase the success. While showcasing the learnings, because we do fail an innovation team. Anyone that's part of an innovation team or that you innovate, you fail, you share your learning. You need to be humble. You need to say that we learned. And the prise de risque, taking risks and failing is as important as succeeding. But the best way to do it when you start is start. Accompany a team, demonstrate that you co-created with the patients or with the staff, measure the impact, showcase it, and then you can do events to share successes and learning and failures. And this is how the innovation team is promoted within an organization.
Cathy, you should also tell about your way of creating networks of ambassadors.
Oh, yes, that was fun. That was fun. So we created, whether it be at Saint-Justine or at the CHUM or any organization, even Montérégie-Ouest, one of the ways also to promote a strong culture innovation is to have the notion of ambassadors of innovation, ambassadors of transformation, ambassadors of change, where you select a couple of individuals per directorate, per department, including patient partners. So when we launched the program Ambassadeurs d'Innovation that we currently train with Paul Mosaïque and Paul Santé, we train now ambassadors of innovation. But at the time, we selected a couple individuals, we offered them short training, and then we expect from them to be the ambassador of innovation within their departments and to lead at least one innovation project within the year, bless you. So that's a way to also promote a strong culture innovation where you don't centralize the expertise to support innovation only in one team. You make sure that in all your departments, you start with N equals 1, and then N equals 2. A second patient partner, a second physician, a second person from hygiene and salubrité like Mary, where you start having the multiplicateur of people that have the competency to innovate and support innovation.
I've been a witness of the the power of this approach. I've seen those ambassadors on the ground in a team meeting with their little pin saying, okay, well, today in the agenda, I mean, everywhere in the hospital, well, I'm kind of health innovation ambassador, and today I'd like to ask if there's something that we could maybe do in our team, and it provokes a conversation. It's everywhere. It's fascinating. There was other questions.
Please ask hard questions too. These are the funnest.
Manas est derrière, on a aussi une personne aussi. Allons-y avec Manas en premier.
Hi, Cathy.
Hey,
A couple of quick questions. Who should own AI in a healthcare organization?
who should held what?
Own. Should it be owned by the chief technology officer?
The
chief
innovation?
data officer? Yeah.
Okay.
AI. who should own
AI.
Yeah, and how should they reduce fear about AI? There's a lot of fear out there
AI.
that AI will
Okay.
take away jobs. So how should the AI person reduce that fear?
I'll only share my experience, okay? Because the science of the chief AI officers is new. There's no right, standard recipe. So I'm also the chief AI officer, whether it be my 3 last organization. In my 3 last, there was a chief AI officer. It was not a chief technology officer. It wasn't. I held both hats, innovation and AI. But I think the most important thing is that, like innovation, AI should be transversal. It shouldn't be only in silo in the IT department. So that's one learning. Needs to be transversal, like innovation. Needs to report to the CEO. That's a second. And shouldn't be niche in IT only. How to reduce fears towards AI? Number 1, education. And I know you share that. Demystifying what AI is. So literacy, increasing AI literacy. Then having, and like we have now obligatory training to wash your hands, we still have obligatory training. Can you imagine? We still do training of how to wash our hands in a hospital, which is pathetic. But I think that AI now is an obligatory training for all the staff of the organization, from the physician to the managers to the administrative agent that support the patient on the units. So education, training, literacy, training, and I always say this is what we did. We did the promptathon, which is a hackathon with a promptathon. So same concept. So you
kind
take
of
problems
a hackathon, but
with prompting
only
engineering.
Prompt.
Yeah, exactly. Using Copilot, for example, as a Copilot to build agents that automatize or produces, for example, a schedule for physiotherapy in the weekend. So the notion of why literacy is good, training is good, but it's not sufficient. You need to get your hands dirty. You need to try. You need to play with AI.
Well, we just learned to wash hands.
Oh, yes, you're right. Yeah, you have to take the training again. So bringing the people on the ground to experiment AI reduces fear of AI.
And you're
while managing, I mean, there is drifts and negative of AI, like any technology throughout history. So you need to do it ethically and responsibly within your organization.
You were officially named Chief AI Officer. What was the kind of guidelines of mission statement for you when?
You really want me to answer this question?
Well, it's
in 2018,
impressive.
we had no mission statement. We created everything. I mean, in 2018, we were maybe in Canada 2 organizations to have chief AI officers. Did we know exactly what to do? No. But we replicated some of the learnings we did for innovation. So you need a 3-pillar strategy. You need ingredients. The difference, though, with AI, it's the speed at which, especially since generative AI, it's just, I've never in my career felt destabilizé, like tomorrow I have to learn something new. Oh, the training we just gave is outdated. We need to update it and retrain. And the speed at which practices, knowledge, competency evolve, this I've personally never experienced in my career.
Something else.
So that's different than any other new recent technology. But mission statement, maybe just to go back and I'll finish on that, the why. We don't do AI to do AI. We do AI to improve lives and should be the same leitmotif as innovation.
First of all, thank you so much, Katie. It was truly inspiring, the talk. And I wanted to ask you a general question, because like I'm from Italy, so we have different health system and different bureaucracy, but I think at the end of the day, the challenges are pretty similar.
The same, yeah.
And,
So surprisingly, yeah.
And my question is, how do you foster adoption of AI in hospitals when the doctors are above 60-year-old and they're not even comfortable in using a laptop? And every time I go to a medical appointment, the doctor always complain, this computer is like nothing works. Like it takes me 30 minutes to make a recipe or like a receipt or something, you know?
Yeah.
And then I wonder how they're struggling. So where does AI come from? How do we adopt AI when there are still basic challenges in using computers?
Excellent question. So 2 points. Some wise people are tech savvy So I want to break this bias that
Not
all
in
our
Italy.
elderly don't know how to use technology. So that's the first thing. Second, however, I like stories, and they're true stories. There was an MD PhD, the 100 most influential women in science in Canada. I'm not going to mention her, but there's one physician, MD PhD, that came to me during COVID. She was an ambassador of innovation. She registered to be an ambassador of innovation. And we were talking also about AI and this technology. She came to me, she had the guts to come to me and say, Kathy, you're talking about AI, I can't even open my Teams yet. She's like, no physician will tell you that they don't know. So thank you for taking the time to train us on basic skills. Digital literacy, for me, c'est un bien commun.
Common good.
A common good. We need to prioritize, and Canada is not doing, I don't know, Italy is doing good, but we are the lowest from the OECD country in AI literacy. Montreal, Canada. Canada is known for its bassin of science and AI, and the literacy of our people is the lowest of the OECD country, which includes this MD, PhD. So never take for granted because you have diplomas that you have high literacy in AI. This is why I responded to Mandan that the key to reduce fear is knowledge. Knowledge is power. And we need to continue to support these physicians, these nurses that are wiser and at the end of their career, how to simply use these tools in their day-to-day life. It starts with tech literacy, data literacy, and then AI literacy.
Makes me realize that, Kathy, when we organized hackathon, one thing we realized quickly from making hackathon successful was to have learning sessions, cafes where we'd learn about each other, we'd learn about technology, we'd learn about the possibilities, and then people said, hey, gives me ideas of things I could do. That's something you did a lot.
Yes, well, we did a lot. We did all this together. I mean, the other core capability and core asset of an organization is learning. Looking at Angie and my team, we're really focusing a lot on the notion of ambient learning. How do we constantly learn? We learn at point of care, learn at point of work. Yes, university, you need to learn and do some certification, but the knowledge is evolving so fast that learning during work, at point of care, at point of work is also essential.
Kathy, we're probably going to have to close this. I know it's a shame, but would you have one last message to share?
Me?
Yes, you.
Yeah, and we're all listening.
And Luc, of course, you always has the last word.
I want to leave you, I think you're never going to forget this. Is innovation essential and possible in health?
Hell yeah! Cathy Malas, mesdames et messieurs.